Hello students, welcome to chapter 66. Remember, this is your interactive blueprint for the final and also for the quizzes. I think it's quiz number 9 and 10 or number 9 only, okay? But also remember that with this new tool that we are proposing, you are able to review the class. You can see my notes on the electronic version of the book. You can also see the videos that explain some procedures from the book. You can also do any activity at home while listening to the recordings. You can fast forward, repeat, you know, stop and repeat the lesson as many times as you want. You can even drive and listening to these recordings. So remember that practice makes perfect, and it's much better tool than having a PowerPoint physically, while you can review the lecture by listening to it. Okay, so enjoy the lecture, and feel free to stop, repeat, or whatever. And also check my comments with the "that's good to know," because those are hints for the final, as I said, and the quizzes. Okay, let's start. Chapter 66, Concepts of Care for Patients with Gynecologic Problems. Gynecologic problems. So, pain, vaginal discharge, abdominal bleeding, and urinary elimination problems are common gynecologic symptoms that are reported by adult women. These problems can impair her feelings about sexuality and intimacy with others, as well as reproduction. Okay, so, okay, let's continue. And what we are going to see right now is a video that I have selected, so it can better explain the sexuality concept exemplar, uterine leioma, okay, which is also well known as fibroids. Okay, so let's see the video. Let's watch the video. Okay, here we go.
A fibroid is a benign tumour that mainly consists of muscular tissue and usually grows inside the uterus. Fibroids are also called myomas. Its size ranges widely from a small tumour the size of a pea to a large tumour almost the size of the uterus. Myomas are classified into 3 types depending on the location where they're found. The intramural myoma, a fibroid that grows in the muscular wall of the uterus. The subserosal myoma, a fibroid located just beneath the outside mucosal covering of the uterus. Here, the fibroid projects to the outside and occasionally remains connected with the uterus only through a small stalk. The submucosal myoma, a tumour that grows beneath the surface of the uterus lining. Therefore, this type of fibroid can grow in the uterine cavity. The actual causes of development of a fibroid are still unclear. However, it has been documented that fibroids are associated with high levels of estrogen, the female sex hormone. Fibroids can only develop during reproductive years of women. Following menopause, the production of estrogen decreases, which will usually cause fibroids to shrink or disappear. Myomas are more common in non-pregnant and infertile women. In general, fibroids are asymptomatic or associated with just a few complaints. If any complaints occur, then the location, size and type of the fibroid are the major factors. Fibroids can affect nearby structures. They can cause compression of the bladder, which may lead to urinary complaints, or may obstruct the intestine, which may result in constipation. Other complaints can be backaches, abdominal problems, menstrual flow disturbances. Fibroids can impede normal childbirth, which may require caesarean delivery. Fibroids relatively more often lead to miscarriages. Whenever fibroids cause symptoms, they need to be removed or shrinked. Medications sometimes cause fibroids to shrink by blocking the production and secretion of estrogen. In other cases, surgery may be required to remove the fibroid. The type of surgery depends on the location of the fibroid. Sometimes it's possible to remove the fibroid with the help of a tube entered through the vagina, and the procedure is called hysteroscopic myomectomy. In other cases, surgery through the abdominal wall may be necessary. In the case of a large fibroid, hysterectomy may be the only solution. This option only applies when there is no desire to have more children. Your general practitioner can give you more information about the disorder and its possible treatments.
Thank you so much. So we learned that fibroids are also called myomas or leiomyoma. Okay, so she explained that there are different types. Intramural leiomyomas are contained in the uterine wall within the myometrium. Submucosal leiomas protrude into the cavity of the uterus and can cause bleeding and disrupt pregnancy. And subserosal leiomyomas protrude through the outer surface of the uterine wall and may extend to the broad ligament, pressing other organs. Although most fibroids develop within the uterine wall, a few may appear in the cervix, called cervical myomas. Pedunculated leiomyomas are attached by a pedicle stalk to the outside of the uterus and occasionally break off and attach to other tissues, parasitic fibroids. Etiology and genetic risk. These fibroids either are diagnosed at a peak time within a woman's early 40s. The incidence of leiomas is 2 to 3 times greater in black women than white women. Vitamin D deficiency, reproductive tract infections, and African ancestry are being examined as risk factors through the study of environment, lifestyle, and fibroids. Known risk factors that are associated with development of leiomyomas include early menarche, that we spoke several times about this in the previous chapter, significant consumption of red meats, use of alcohol, and hypertension. Somehow at some point, I think I mentioned finally the American Cancer Society gave a statement about the red meat and its relation with cancer. Gene studies show a connection between development of leiomyomas and family history of such. So that's good to know. All of this in this paragraph is excellent information. So vitamin D deficiency is very well documented. The deficiency in this vitamin is related with cancer, reproductive tract infection. Oh, let me repeat about vitamin D. I spoke also in another lecture that vitamin D needs to be supplemented based on your blood work. It's not that you go and you buy the amount and the units of vitamin D that you like. No, you have to get your blood work done and get the recommendation of the doctor. Vitamin D has to be in the exact level, okay? So normal levels is between 30 and 100 vitamin D. You don't want to be on 26, even though, oh, 32, sorry, even though the doctor is going to tell you is within normal limits, but it's still on the low side. You always want to be on the upper limit. So for example, if it's between 30 and 100, the normal levels, you want to be between 70 and above, close to 100. Never above 100. Never below 30. Okay, just a reminder. If you get vitamin level of 50, it's a normal, but it's not protective. Protective would be in the upper limits, okay? Okay, so that's good to know. Let's continue with assessment, recognize clues. Some women with fibroids do not experience pain, but others do. She may experience dyspareunia, which is a painful intercourse, depending on the location of the leiomyoma. Acute discomfort may occur with twisting of the fibroid on its stalk. Many women with leiomyomas report painful menstruation, often with heavy flow and the presence of clots, and that's good to know as well. Dyspareunia, painful intercourse in the presence of leiomyomas. The patient often seeks medical attention because of heavy vaginal bleeding. Ask about how many tampons or menstrual pads she uses in a day. Establish whether she has a predictable menstrual pattern, if she experiences intermenstrual bleeding between periods, and if she has prolonged bleeding, periods that exceeded the normal 5 to 6 days. Determine if she has a feeling of pelvic pressure and altered elimination patterns, including constipation and urinary frequency or retention. These symptoms result when the enlarged fibroid presses on other organs, and that's good to know, okay? Very important information. The patient may notice that her abdomen has increased in size. This is a very classical symptom. Assess the woman's abdomen for distension or enlargement. Abdominal, vaginal, and rectal examinations performed by the healthcare provider usually reveal the presence of a uterine enlargement. Diagnostic assessments. An endometrial biopsy may be performed to evaluate for endometrial cancer. Transvaginal ultrasound, a procedure in which the ultrasound probe is placed into the vagina for visualization, is the diagnostic study of choice. Saline infusion, sonography, hysteroscopy, and MRI, which can differentiate between benign and malignant tumors, may also be ordered if the transvaginal ultrasound results are inconclusive. Just to remind you that when we talk about fibroids, we are talking about these masses within the uterus, right? And the lining of the uterus is called endometrium. So when we talk about uterus and we find a fibroid in the lining of the uterus, we are talking about endometrium as well. Okay, so don't get confused. It's the same topic. We are talking about fibroids. Fibroids are in the uterus, and you have to be very clear on that. The priority collaborative problem for patients with uterine leiomyoma is potential for prolonged or heavy bleeding due to abnormal uterine growth. Okay, so how are we going to manage the bleeding? Interventions. Asymptomatic leiomyomas may not require treatments. Leiomyomas in menopausal women usually shrink, so surgery may not be necessary. Think about then this estrogen role in these leiomyomas. So when the estrogen is not produced in such a big quantity because during menopause the ovarian are not producing estrogen, the leiomyomas are going to shrink because basically they are there because of the estrogen, right? So non-surgical management. Mild leiomyoma symptoms can be managed with hormonal therapies. The choice of oral contraceptives is based on the woman's risk factor, co-occurring disorders, and personal symptoms associated with the leiomyoma. Myolysis is a laparoscopic thermal, radiofrequency, or cryoablation of a leiomyoma tissue. Most women report an increased quality in life after these procedures, although it does bear risk of addition formation. Uterine artery embolization, also called uterine fibroid embolization, performed under local anesthesia or with sedation is performed if the patient requests it. And we are going to watch the video to see how is the uterine artery embolization performed.
This video has been produced to familiarize you with the uterine fibroid embolization procedure, UFE. UFE is a safe, effective treatment for fibroids that has been performed for nearly 20 years. It is one of several treatments that may be used to treat fibroids in the uterus. Uterine fibroids are non-cancerous growths that develop from normal uterine muscle cells. There are 4 types of fibroids that develop in or just outside of the uterus. Submucosal fibroids grow into the uterine cavity. Intramural fibroids grow within the wall of the uterus, and subserosal fibroids develop on the outside of the uterus. Pedunculated uterine fibroids occur when a fibroid tumor grows on a stalk, resulting in pedunculated submucosal or subserosal fibroids. All fibroids require a supply of blood to survive and grow. UFE takes advantage of this fact to target the fibroids. Uterine fibroid embolization is a minimally invasive procedure. UFE does not remove the uterus or the ovaries. A small incision is made in the leg to gain access to the femoral artery. A long flexible tube called a catheter is then inserted into the femoral artery. It is guided up the femoral artery and into the artery that supplies blood to the uterus, called the uterine artery. The catheter is then guided to smaller arteries that supply blood to the fibroids. Uterine fibroid embolization delivers tiny microspheres to the artery that supplies the fibroids, cutting off the blood flow, causing the fibroids to shrink. The tiny microspheres are injected through the catheter and travel through the blood vessel. Since the microspheres are more than 60 times larger than red blood cells, they plug the tiny vessels that red blood cells travel through to feed the fibroid. The procedure is repeated in the uterine artery on the other side to make sure that all blood supply to the fibroids has been cut off. All fibroids are treated simultaneously. Once the blood supply to the fibroids has been blocked, the fibroids begin to shrink. There is no scar tissue and minimal blood loss with UFE. Recurrence of the fibroids with uterine fibroid embolization is rare. Most women are able to return to light activity within a few days of the UFE treatment and are usually back to work and normal activity, on average, within 11 days. Take back your life today. Ask your doctor if uterine fibroid embolization is the right treatment for you.
Wow, the approach is very interesting, is amazing, and has minimal side effects, minimal risk. The uterine artery embolization is a very good procedure. Common concerns reported following uterine artery embolization include pelvic pain, which is most severe in the first 24 hours, and vaginal discharge, which is self-limiting and can last for months. Teach her to resume usual activities slowly and avoid strenuous activity until the surgeon recommends it. Most patients can return to work or daily routine within a week. Excellent. Safety, safety, nursing safety priority. After uterine artery embolization, UAE, the woman may have severe cramping within the first 24 hours owing to tissue necrosis. We know that. Cramping can last from a few days to 2 weeks. Patient-controlled analgesia (PCA) is often used before transition to oral pain medication. What happened here? No. Okay. So, cramping can last from a few days to 2 weeks. Patient-controlled analgesia (PCA) is often used before transition to oral pain medication. And PCA is used in the healthcare setting, right? An oral pain medication is going to be used at home setting. Remind the patient how to use PCA most effectively while hospitalized. They will give you like a remote control button, something like that, that you can press when the pain is severe, and the pump is going to deliver a certain amount of analgesia. If she experiences fever, nausea, and malaise with the pain known as post-embolization syndrome, or if severe pain or indication of infection is present, such as purulent vaginal drainage and fever, a continued hospital stay or readmission may be needed. And that's good to know. You have to monitor, and you have to teach the patient to monitor for those symptoms of infection. And this recommendation is repeated over and over and over every single procedure that we have studied over the semester, okay, in terms of how recognize symptoms of infection. Uterus sparing surgeries. If the woman desires children, the surgeon may perform a laparoscopic or hysteroscopic myomectomy, the removal of leiomyomas from the uterus. Laparoscopic myomectomy performed on an outpatient basis or within a day hospital stay is used to remove leiomyomas that are intramural or subserosal, right? Subserosal are the one that are in the wall of the uterus, but kind of in the outside border. Hysteroscopic myomectomy is done to remove intracavity leiomyomas. During this procedure, a laser may be used to remove the tumors. Okay. Nursing safety priority. Critical rescue. Monitor for rare but potential complications of hysteroscopic surgery, which include fluid overload. Fluid used to distend the uterine cavity can be absorbed. Embolism, hemorrhage, perforation of the uterus, bowel or bladder, and uterine injury, persistent increased menstrual bleeding, incomplete suppression of menstruation. Hysterectomy leiomyomas are very common reason that a hysterectomy is performed. Hysterectomies may be performed abdominally, vaginally, or with laparoscopic or robotic assistance. These last two are more common, the laparoscopic, and lately the robotic assistance is used very often lately. Okay, so here you have the setting, the operating room layout for robotic surgery with Da Vinci robotic surgery system. You see, the doctor is basically operating through a screen. It's a screen that he's watching, and his hands are inserted in. They are holding some tools that are manually and robotically performing. So he's guiding the robot, basically. Common gynecologic surgeries, you have total hysterectomy, the removal of the entire uterus, including the cervix, is removed. And we know that the cervix is the door, the entrance to the uterus, right? Is this donut shape that you can see is very shiny donut shape at the beginning of the uterus, at the beginning of the pathway that is the entrance to the uterus, right? Then you have the supracervical hysterectomy, also called subtotal or partial hysterectomy. Is the upper part of the uterus that is removed. However, the cervix is left in place. So it's the upper part. Okay. Now the salpingo-oophorectomy, fallopian tools, which is the part that relates to the salpingo, and ovaries, ovaries is the oophorectomy, are removed. This can be done on one side of the body or both. Okay, so they can remove the fallopian tube on the right side and the ovarian on the right side, or they can remove fallopian in both sides and ovaries in both sides. If only the fallopian tubes are removed, it is called salpingectomy. And if only the ovaries are removed, is oophorectomy. For patients at risk of ovarian or breast cancer who choose to have both ovary removed, even if healthy, in order to decrease their risk of developing cancer, it is a risk reducing bilateral salpingo-oophorectomy. Radical hysterectomy is the removal of the uterus, the cervix, the adjacent lymph nodes, upper third of the vagina, and surrounding tissues parametrium are removed. That's the radical hysterectomy. Okay, so focus assessment, postoperative nursing care of the patient after open total abdominal hysterectomy. Total abdominal hysterectomy. So the assessment is going to focus on activity tolerance level, heart, lungs, and bowel sounds, right? We want to know if there is presence of bleeding. We want to know if there is pain in the site of incision, fluid intake, IV, until peristalsis returns and patient is tolerating oral intake. We want to assess patients with vaginal hysterectomy, if the perineal care, how perineal paths for vaginal bleeding and clots should be less than one saturated perineal path in 4 hours, and that's good to know. Okay, if the total abdominal hysterectomy, if the hysterectomy is done through the vaginal hysterectomy, if this procedure is vaginally, then you have to monitor for vaginal bleeding and clots, and should be less than one saturated perineal pad in 4 hours, right? So if it's one vaginally in 4 hours, if two saturated pads are in 2 hours, that means that this is too much, right? And you need to report it. So there is excessive bleeding. Remember, it's one saturated perineal pad in 4 hours. So in 8 hours, it should be 2 saturated perineal pads, right? Operative procedures. Hysterectomy can be performed in several ways: vaginally, abdominally, laparoscopically, or via robotic assisted laparoscopy. The choice of route is based on best approach to treatment of the underlying condition, risk and benefits of route, the need to treat additional conditions, patient preference, surgeon's skill set, preference, and facility availability. Okay. Post-operative care. Nursing care of the woman who has undergone a total abdominal hysterectomy is similar to that of any patient who has had laparoscopic or traditional open abdominal surgery. So the nursing care is the same. You have your NCLEX questions, and I would like to add that besides this is a interactive blueprint, and you need to pay attention to all that's good to know hints for quizzes and exams. Be careful and double check all your NCLEX examination challenge questions, as well as your mastery questions that are at the end of every chapter. Before the references, you're going to be 2 or 3 extra questions. Review all of them, because probably I'm going to get questions from here, from the test bank of this book, from test bank from different other sources, other books, right? So the only thing that I would promise you, I will guarantee that all the subjects that I'm going to test, you will find the answer in the chapter of this book. I personally review and I make sure that everything that is tested, you will find the answer in your book. I can test from different points of view using different books that they have different test banks, but always the answer is going to be here in the book. That's what I can tell you. I guarantee 100%. Home care management. If the patient had a laparoscopic hysterectomy, few limitations in activity are needed. Teach patient who had a vaginal hysterectomy or traditional open hysterectomy to limit stair climbing for several weeks. If women live alone and are not permitted to drive for several weeks, they may need to arrange for transportation for follow-up surgical visits. And basically is to rest those muscles that are related to stair climbing, or when you drive, you may think that you are not using the muscles of your surgery, but you are when you are controlling the pedals, the brake, the accelerator. You are using them. Okay? Self-management education. Teach the woman who has undergone an abdominal hysterectomy about the expected physical changes, any activity restrictions, diet, sexual activity, wound care, if any, complications, and the need for follow-up care. Some women experience abdominal or shoulder discomfort because of the introduction of carbon dioxide gas during a laparoscopic procedure. Teach patient who had a vaginal hysterectomy to promptly report excessive or increased bleeding to their surgeon, as I explained before, right? Okay. Care after a total vaginal or abdominal hysterectomy. This is the care. Expected physical changes. You will no longer have a period, although you may have some vaginal discharge, right? So you have a hysterectomy, no more periods. It will not be possible for you to become pregnant. If your ovaries were removed, you may experience menopause symptoms such as hot flashes, night sweats, and vaginal dryness. It is normal to tire more easily and require more sleep and rest during the first few weeks after surgery. Activity typically for vaginal and traditional open surgeries. Limit stair climbing to fewer than 5 times per day. Do not lift anything heavier than 5 to 10 pounds. That's a good restriction. 5 to 10 pounds. It seems nothing, but you pay attention to this. Avoid sitting position for extended periods. That includes when you sit, do not cross your legs at the knees. So that includes your driving habits, okay? Avoid strenuous activities. And that's good to know, the sitting position. Pay attention to the sitting position. That's good to know. Sexual activity. You cannot, right, have intercourse for a few weeks because the vaginal walls are tighter. Careful intercourse when you are finally authorized must be performed, and the use of water-based lubricants can help reduce this discomfort. It usually goes away with time and stretching of the vagina. Okay, so it's 6 weeks of restriction of having sexual intercourse. Complications. Report fever of over 100. Check any incisions daily for signs and symptoms of infection, increasing redness, open areas, drainage that is thick or foul smelling, incision pain. Symptoms to report to your surgeon: increased vaginal discharge, drainage, bloodier, thicker, or foul smelling, signs of infection. Those are the most important. Healthcare resources, if desired and culturally appropriate, refer the woman to a religious or spiritual leader or a community support group to discuss feelings of sadness. Women identified as being at high risk for psychological problems may need long-term follow-up and referral to a mental health counselor or clinical psychologist, particularly if they exhibit symptoms of depression. I would strongly recommend do not wait for these nursing interventions or referrals post-surgery. Before the surgery is performed, try to assess if this patient is gonna need that. You can easily identify patients that are having risk for anxiety, depression, or change in their mental state even before surgery. So you can be prepared to put and organize all the different recommendations and referrals you may need post-surgery. Let's make a quick break and let's come back for part 2 of chapter 66. I'll see you, I'll talk to you in a minute.